last chapter in this discussion is Chapter 10, which is the regulation of calcium and phosphate balance. Ultimately, the kidney is not the only mechanism that's controlling this. It's part of a complex system. Okay, the complex system involves the bone as well as GI tract. The GI tract being a major player. Okay, but the kidney does have a certain importance, and the reason it's important for this discussion is when you go into pathophysiology when the person develops kidney failure. Okay, in kidney failure, that's when calcium and phosphate balance can become significantly dangerous to an individual. Calcium is essential, but it has to be highly regulated. Okay? If you don't have enough calcium in your bloodstream, you will die. If you have too much calcium, you'll die. So both ends is bad. Okay? Calcium, when it's ionized, is extremely toxic to cells, so it can only be at a certain level before it becomes a toxic equivalent. The way it's regulated, it requires two major organ systems. It involves the GI tract, kidney, and the buffering capacity of the bone. So there's basically three organ systems that are involved, okay, with the buffering capacity of the bone being the long-term regulator. Okay? Because most calcium is actually in your body is in the form of bone. Okay? It's embedded. It's not going to go anywhere. The nice thing about it is that if you decide to go out in the woods, okay, and you don't have any available calcium, that your body does have a nicely available store, which is your bone. It will begin to break down your bone to get the calcium back intracellular and back intravascular. The two time scales of calcium balance is rapid or slow. Rapid is what's important for regulating the ionized calcium levels, and it's basically accomplished by shifting calcium in and out of the bone. Okay? Slow ingestion and excretion is the most important, as ingestion is via the GI tract. Okay? If you lack of calcium during childhood, it leads to problems such as rickets. Okay? Lack of calcium during adult life can lead to things like osteomalacia and osteoporosis. Women that are really small-framed have a very high risk of developing osteoporosis. Okay? So if you're thin, make sure that you're constantly taking in your dietary extra supplements of calcium, which can make a significant difference. Okay? As women get older, because they have smaller bone frames than men, they're much more likely to develop hip fractures, and that's one of the leading causes of death in women between the ages of 70 to 80. Okay? So osteoporosis can become a significant problem in certain of the population. Long-term regulation of total calcium is in the bone. The kidneys play an indirect role of helping excrete some calcium in the urine, but also the important part of the kidney is it forms vitamin D. Okay? Calcium exists in basically three forms. Its ionized fraction is by far the only part that's biologically active, so that's the only part that's important. Unfortunately, if you work in a normal hospital in the old days, say 10 years ago, the only calcium that you got was a combined calcium, and you didn't know what the ionized fraction was. Okay? What we came up with at that time to sort of make ourselves feel better is we would say, well, look, check the albumin, and from that you can calculate how much percentage of it would be ionized. And when reality was that was totally fake. Okay? It has no relationship at all. So if you're working in a hospital where they're giving you total calcium, that is a worthless test. You got to get the pathology department to switch over to an ionized calcium level, which is what's critical in the operating room. Okay? If you don't have an ionized calcium, you're guessing therapy at that point. You're just guessing. The reason ionized calcium is so important is because that's what the cell uses as a biologically active component. Okay? It's what's used at the neuromuscular junction. Okay? It's responsible for calcium uptake into the cell to help contraction. Okay? It's also important for vacuole release. So it has a lot of important levels at the neural and as well as muscular components. The other way that calcium exists is in complex with anions, okay, and complex with plasma proteins, which is albumin. The role of calcium is the extracellular fluid calcium triggers exocytosis of hormones and neurotransmitters, which we've shown you in the first semester. It helps signal contraction in smooth muscle and cardiac muscle. It regulates the threshold for excitation of nerve and muscle cells, and it's important also for the coagulation mechanisms. It's one of the critical components of coagulation. If you don't have enough calcium that's ionized, then your clotting cascade is totally inefficient, and it actually will not form fibrin as a consequence. The effector sites for calcium balance are going to be the GI tract, the kidney, and the bone. The GI tract by far is the most important, okay, where most calcium is unfortunately not absorbed. Okay, your system is not set up to absorb high levels of calcium. The hormonal mechanisms that can control the GI tract are important. And why we use this mechanism is calcium tends to precipitate easily, so filtration to the kidneys would increase the risk of stone formation. So your body does not like the idea of pulling in a lot of calcium into it, okay? Because then it's got to get rid of it. So the system is set up basically to hold out calcium, okay? Which is not a good thing in the sense that if you're becoming depleted of it, it's actually easy to deplete yourself of calcium. The kidneys eventually do filter and to a certain degree will reabsorb calcium. 60% of filtered is not protein bound, and you're looking at reabsorption-wise, 60% occurs in the proximal tubule. Again, that's pretty common. Almost everything is in the proximal tubule, 60%. The thick ascending loop of Henle is also a passive event, it also reabsorbs. And the actual, most of the regulatory mechanisms of the distal convoluted tubule, which has active and transcellular mechanisms, and this is where the endocrine controls the renal calcium handling. Okay, so the distal convoluted tubule is really the main mechanism where calcium regulation takes place in the kidney. Calcium is usually not secreted. It's actively trying to be reabsorbed. Okay? The renal homeostatic mechanism is if you have calcium that's being excreted, it's equal to the filtered load versus the reabsorbed. So if you want to have more excretion, then you stop reabsorbing it, okay? Or you increase the filtration rate process. Now, certain kinds of dietary intakes have very high levels of calcium, okay? And especially in Florida, if you're in a chronically dehydrated state, and if you drink a certain kind of drink a lot, okay, which a lot of us in Florida like to because we have orange trees, you have a much higher propensity of developing stones. So calcium stones are the more common cause of kidney stones, and that can develop just by drinking too much orange juice. If you drink orange juice every morning, your propensity of having kidney stones goes up tremendously. So if you do like orange juice, just do it like once a week. It's a little bit easier on you. Of course, you have genetics are an important part, which we'll talk about in pathophysiology of what stones are. Okay. What you have here is what actually controls calcium. Calcium regulation at the kidney is controlled by the parathyroid hormone. Okay? The parathyroid hormone, of course, is the hormone that's being released by the gland that's posterior to the thyroid gland called the parathyroid gland. Okay? The parathyroid glands, there's usually 4 of them. Okay? 2 in each isthmus out here in lateral aspects. The thing about parathyroid glands is that if you do a total thyroidectomy, you can remove all the production of parathyroid hormone as a consequence. So what happens to your calcium levels all of a sudden? If you can't reabsorb it, okay, which is what parathyroid hormone does, is then you get hypocalcemia. Okay, so people can become very symptomatic, have very bad arrhythmias, and become significantly hypotensive after a parathyroidectomy. If they did a thyroidectomy and did a parathyroidectomy in the process. So parathyroid hormone is very important for reuptake of calcium. Factors affecting renal handling of calcium is, again, if you're not secreting it, you can only alter either the filtration rate or you alter the reabsorption rate. So that's the only way you can regulate calcium. Okay? Hyponatremia can lead to a decrease in calcium reabsorption. Okay? So these are things that you have to memorize. This is one of those things that I can't really tell you the best way to memorize it. It makes no logical sense, so I have a hard time explaining this to students. This is one I have to tell you that you have to do memorize. Okay? But hyponatremia will lead to a decrease in calcium reabsorption. Let's see if I can actually make some kind of mechanism. I would say that the most likely reason for this is that once you develop hyponatremia, the kidney will not be as efficient in their process to pull sodium back into the cell, okay, and maybe establish a gradient to help the the system move along. But again, the best way to do this is just memorize it. There's really no good explanation that I can come up with as to why hyponatremia leads to a decrease in calcium reabsorption. Acidosis also leads to a decreased calcium reabsorption, and alkalosis leads to an increase in calcium reabsorption. So these are completely opposite mechanisms. Okay, so acidosis leads to decrease, and hyponatremia leads to a decrease. Now the next system is the bone. Okay, the bone is crucial for calcium as a buffering system. It's really the major repository of calcium, and it uses osteoclastic osteolysis to release calcium into the bloodstream. Here's the mechanism that I've drawn for you to sort of establish this kind of mechanism you have in place. What I've done for you is that you have three basic mechanisms that are inside these like hexagons. Okay, the bone, kidney, and intestine are the major organ systems that are involved in calcium regulation. You'll see that the plasma calcium levels, okay, are what's trying to be maintained at all costs. Okay, some of it is maintained by the uptake of calcium via the GI tract, and then the buffering capacity is made established by the bone to try to keep the plasma calcium levels importantly steady. The kidney can actually filter, but it'll reabsorb a certain percentage of the calcium to try to maintain a steady state in it as well. And then it can excrete some of it basically by not reabsorbing it into the urine. Okay? The other way, the majority of calcium that's excreted out of your system is via the stool. Okay? Because it's not, even though you drink a lot of calcium, you don't uptake a lot of it. So most of it is actually removed and gets out of your system via stool in your diet. Now, what actually controls the other systems, which is the GI tract system, is to a certain degree vitamin D. Okay? Vitamin D stimulates calcium and phosphate intestinal absorption. Okay? So really, for vitamin D to be lacking in an individual, no matter how much calcium you give that individual, they won't reabsorb. What causes rickets is not so much as a lack of calcium in the person's diet, it's that a lack of active form of vitamin D. Okay? If you go back to Britain in the 1800s, one of the things that they had during that time was that London had a fog. Okay? Well, London fog is not really fog, it's smog. It was a byproduct of all the coal they were burning in their houses. Okay? If you go to London now, there's no fog. Okay? It's actually a disappointment. And when you go to London, you always expect like gloomy little place. You know, it's not like that at all. Instead, you have a very normal city like you have in the United States. Okay, but in those days, that the smog was so heavy that the sunlight was not penetrating into the slum areas of the city, because they would use dirtier coal to fuel their fires. So these kids were not getting exposure to UV light at all. It's literally protecting them from ultraviolet radiation. The benefit of it was that they weren't going to get skin cancer. The bad benefit of it is that they were not converting their vitamin D into active form. And as a consequence, they were developing rickets. Okay, even though they're having their major source of food usually was milk and oatmeal. Okay, milk and oatmeal have a lot of calcium in it, so it doesn't really understand why that person would become hypocalcemic. And that's why. It's from the lack of active form of vitamin D. What we've done over the years is we've taken the active form of vitamin D and put it into our milk. Okay, if you look at all these milks, it says fortified. That's what it means. It's an active form of vitamin D that's been put into the milk. Okay, so all school milk has active vitamin D in it. Normally, what you see is that the active form requires exposure to sunlight and then processing in the liver, which is the active form of vitamin D is calcitriol. You have to know that one. Okay, that's another test question. What's the active form of vitamin D? It's not vitamin D, it's actually calcitriol. Okay. Now, what else affects regulation? Parathyroid gland is very important for regulation of calcium. Parathyroid hormone controls the extracellular calcium levels. Increased levels of parathyroid hormone basically leads to decreased calcium levels, okay? An increase in phosphate levels, okay? Decreased release of parathyroid, sorry, let me back up. That doesn't make sense, okay? Back up. let me reiterate this. What leads to an increased release of parathyroid hormone? Okay, which is, in other words, the parathyroid hormone is a gland that's going to be activated or inhibited by something. Okay, so when you read this slide, please make sure that you understand that what causes the parathyroid hormone to be released is if you have decreased calcium levels. Okay, because parathyroid hormone is going to cause an increased reabsorption of calcium at the kidney. So it's going to drive calcium back up. Okay? So parathyroid hormone is going to be stimulated by a decrease in calcium levels and an increase in phosphate levels. Okay? At the other end of it, what causes a decrease in release of parathyroid hormone gland by the parathyroid gland, okay, will be an increased calcium, increased levels of calcitriol, and decreased phosphate. Okay? The effects of normal parathyroid hormone is that it does several things. Okay? One, it breaks down bone, increasing intracellular calcium. So parathyroid hormone is going to do everything it can to drive calcium back up. So that makes sense. If you think of it that way, then parathyroid hormone is going to cause breakdown of bone. It's going to cause the kidney to reabsorb more calcium, okay, which it does. And it's also going to cause an activation of vitamin D. So it's going to form more calcitriol, which is going to aid in the GI reuptake of calcium. So it's doing everything it can to try to increase calcium levels in the system. The danger of driving up calcium is that if you have an equivalent level of phosphate, it will bind and crystallize in your bloodstream. And that's really bad news. Okay? I've never forgot that we had to take care of a renal patient who had hyperphosphatemia. It was incredibly high levels. Okay? And we needed to put an A-line in this individual. And what was happening was he was having small embolic phenomena taking place. And when we put in the radial artery, we actually heard a crunch. And when we put in the actual 20-gauge angiocath in. And we fed the catheter in, no problems at all. Okay? But it was one of the hardest A-lines I'd ever put in. Okay? What was interesting was 3 days later when they pulled the A-line out, they couldn't get the bleeding to stop. Okay? And when we brought the patient back to the operating room to try to fix it, the surgeon had to just ligate the radial artery because they couldn't get it to stop. Okay? Every time they would put a stitch into it, the artery would crack. It was so full of phosphate calcium crystallization in the artery that it had become like a stone. You can't suture stone. You need tissue. Okay? So these are the kind of things that are really not good to see. Okay? If you see that high level of calcium and phosphate, then it drives and forms calcium phosphate stones, and you start getting kidney stones as well. Okay? So the body always tries to do the opposite. If calcium's coming up, the body drives phosphate out. Okay? If it sees calcium is rising, if calcium is falling, phosphate then rises. So they're always going in opposite directions. They're always in opposite seesaws. Okay? So here's what I've done for you is I've added the next level of complexity, what actually controls these things. So in the red is the parathyroid hormone. The parathyroid hormone causes an increase in reabsorption of calcium from the bone. It increases reuptake by activation of vitamin D into calcitriol, which is really, it causes a tremendous increase in uptake of calcium via the GI tract. And it causes a parathyroid hormone increased levels of reabsorption by the kidney. Okay, so this is a nice just little visual way of looking at how this mechanism is activated. And the other way is also by looking at the parathyroid gland is what activates it. Low levels of calcium and high levels of phosphate will cause a positive influence of releasing parathyroid hormone. Eventually, the negative feedback loop that shuts off the parathyroid hormone is increasing levels of calcitriol, as well as increasing levels of plasma ionized calcium. Those both will eventually lead to negative feedbacks. That's why they're red arrows to shut the system down. But what this is showing you, again, conversion of bone into ionized calcium, and a conversion of the kidney to reabsorb calcium, and then how the parathyroid hormone eventually causes activation of the 7-cholesterol from sunlight to vitamin D3, and then vitamin D3, which is called vitamin D, into calcitriol, which is the active format, which is what parathyroid hormone does. It activates it. Okay? Calcitriol then in fact eventually causes the GI tract to increase its calcium and phosphate absorption, and as a consequence increases the calcium levels. Now, as for phosphate handling, phosphate is responsible for the hydrogen ions in the distal tubule. Okay? Phosphate is easily freely filtered, and its Tmax is very near the normal filter load. So if filter load increases, phosphate is spilled in the urine very easily. The good thing is that acidosis increases the release of phosphate into the plasma, and it leads to an increase in filtered load, so more phosphate is released into the urine. And that kind of makes sense. If you think about it, phosphate is an end byproduct of high utilization of ATP, so it's kind of nice that the system has an overflow mechanism. When you produce too much phosphate from too much exercise, that you're going to be able to waste the phosphate so it doesn't ionize with the calcium and form crystals. So as you increase metabolism or increase your workload, phosphate tends to be released more readily into the urine. And once it gets into the urine, it uptakes hydrogen ion, neutralizing the acidosis, and it will actually lead to act as a sink. Other factors that also improve renal handling is parathyroid hormone and vitamin D, which also help waste phosphate in the process. So this is what happens with phosphate. Okay? With plasma phosphate, you'll see that parathyroid hormone, when it's increased, will lead to an increase in phosphate levels, which then increases the amount of renal load. So what eventually you see is a much higher phosphate removal rate. Okay? The GI tract is going to be causing activation, and it does increase the phosphate reabsorption through the GI tract. But when you do that, it increases the actual phosphate in the bloodstream, but then dumps it out in the kidney. So the kidney is very important for removing phosphate. Okay? If you develop renal failure in an individual, one of the things that they will develop very quickly is they'll develop hyperphosphatemia. Okay? They will start accumulating phosphate levels that are too high, and that can be a problem. So the way we treat these individuals is that we bind the phosphate in the diet, okay? Which is, what's that material called? Was it? Phoslo. Very good. Phoslo. We always tell the patients to drink that before a meal, and when they eat their meal, it binds to the phosphate that's in the food, and that way it doesn't get uptaken, and because the kidneys can't get rid of it. Okay? Summary of reabsorption and secretion of the major tubular segments. Okay? This is to show you that most things are being reabsorbed in the proximal tubule. R means reabsorbed. S means for secretion. Okay? Look at the collecting duct system. Urea is the one that's responsible for the collecting duct system. It's being reabsorbed. Okay? When you're looking at other compounds like sodium, it's being reabsorbed to the whole system. Okay? This is the kind of things that you sort of need to look at, make sure you sort of understand it. This ties in with the prior box that I was showing you before this lecture. Again, this is things that I expect you to know for your test. Again, just trying to help you know what I want you to know. Principal cells, I don't want you to know the exact mechanism of this, but I want you to know what they do, and that's obvious. Okay? So type principal cells reabsorb sodium by stimulation of aldosterone. They also secrete potassium. They reabsorb water. Type A intercalated cells are the ones responsible for hydrogen ion balance. Okay, they're the ones that they're going to waste hydrogen ions and pull bicarb back in. And they're also going to be responsible for reabsorbing potassium. The type B cells are the ones that are responsible for secreting bicarb and holding hydrogen ions back in an alkalotic state. And they're also going to be responsible for resorbing chloride as well. And the last one is the one that's also going to be on your test. This is, I think, is important. Clinical question. Okay, so I'm going to ask you like 3 questions on this. So know this one as well. These are your class of diuretics. If you're covering this in pharmacology, you should have covered it already. There's only 4 classes of diuretics that are available. There's the carbonic anhydrase inhibitor, the loop diuretics, diazides, and the potassium-sparing diuretics. Okay? The carbonic anhydrase inhibitors work by inhibiting secretion of hydrogen ions and cause less reabsorption than bicarbonate. and sodium, and this takes place at the proximal tubule. So their main mechanism of action is at the proximal tubule. You have to know where they're working at and what they do. Okay, that's what I expect you to know about these drugs. Loop diuretics work at the loop of Henle. Okay? They usually work in a thick ascending loop of Henle because they poison the sodium pump. Okay? And that's what accounts for diluting and causing basically the water not to come out anymore. Okay? It inhibits the sodium-potassium chloride transport and aluminal transport mechanism. Thiazide diuretics, on the other hand, work in the distal convoluted tubule. Thiazides inhibit your sodium chloride co-transport in the luminal side. Okay? And that causes sodium not to be secreted, not to be reabsorbed in the consequence. Okay? And as a consequence, the water stays inside the urine. And the last one is the potassium-sparing diuretics. Okay? These are the things that inhibit the action of aldosterone, and they work on the cortical collecting duct system. Okay? They also work by blocking sodium channels in the luminal membrane, the collecting duct system, so they have two mechanisms of action. And that's what I expect you to know for the test. Okay? So just pay attention to those 4 tables. If you know those really well, the other chapters are sort of helping, but that's your guide to learn the material for the test. If you know those tables, you should do fine the test.